IVM.
Welcome to All Things Policy, a daily podcast supported by Pragati, a flagship media initiative of the Takshashila Institution. We're a bunch of policy nerds based in Bengaluru, and we like to bring a fresh perspective to Indian affairs and an Indian perspective to global affairs. So grab a cup of coffee, sit back, and join us for today's chat.
Hello and welcome to another episode of All Things Policy. I'm Harshit. I work as a research analyst at Takshashila Institution. Today as our guest we have Priyal. She works with me as a research analyst at Takshashila. So Priyal, how are you?
I'm doing good, Harshit. So good to be here.
Yeah, so this is the second part of our two-part series. This is a continuation of a podcast we did on Monday last week. In that we talked about how is primary healthcare important, why we should fund primary healthcare, and we started talking about funding healthcare. In this podcast,
Right.
we try to cover how should we do that and what is the best way of doing that. So the discussion is sort of like based on and talks a lot about the latest Lancet report on financing primary healthcare. So Priyal, continuing with our previous talk, what do you think exactly are the challenges when we talk about funding primary healthcare?
Right. So, I think continuing with the last podcast, right, we spoke about primary healthcare and stuff, and essentially we spoke a lot about why funding is essential to improving you remember we spoke about the circle, right? There's not
Yeah.
enough people who coming in there, and then sort of because of which there is not enough funding, and because there's not enough funding, people don't essentially come there anymore. It's sort of like running around the same bush of the problem. I think one of the problem with or the challenges in funding for the healthcare is limited tax revenues. Also I remember reading that just because there is a lot of budget allocated to primary budget allocated does not necessarily mean that there is enough money allocated for health. A lot of times health doesn't take a first priority in a lot of countries, and which puts funding for healthcare at backseat, right? Countries might prioritize different things like military, defense, and technology and all of that at the forefront, which is why a lot of times health takes a backseat. And that is what we've seen during COVID. A lot of countries who were struggling to battle with COVID or coming up with, testing and contact tracing and everything, you knew that health was not the priority till then. And I think another one of the challenges that I feel is that there is excessive reliance on out of pocket spending. So a lot of people have to pay extra even for their medicines and extra services and everything. So I think these are some of the challenges that I personally find in funding for health and stuff.
One thing I would like to add is donor funding. That is
Right.
basically, if you look at large foundations, large international foundations who are funding a lot of projects, for instance, the Bill and Melinda Gates Foundation, basically bankrolled a lot of, at least the initial stages of the polio elimination effort
Right.
in the country. So they are very fragmented and they do not depend on the priorities of the government. They are dependent on donor priorities and donors, sort of like donors' whims and wishes.
Right.
The government cannot control them. And furthermore, what we want is shifting of the funds from being disease specific to more focused on primary healthcare
Right.
essential
Right.
functions. Usually, donor funding, they who's the donor or whatever the donor is getting, whatever the organization, whomsoever the organization is getting funds from, they need to. What perception is that they need to see that we have reduced polio by 50%, that we have rid malaria from this poor third world country, and sort of like those things. Primary healthcare is not that shiny thing you can wave around and be sort of like, oh yes, this is good. And I liked how you talked about how more government funding does not necessarily mean greater allocation to health, because unless the political situation in the country, unless there's an intent, more government or more tax revenue or more funds does not translate it to more sort of like funds for health.
Yeah,
And
I mean, what I was trying to say was also that political will is important, right? I mean, if there is no political will, then obviously healthcare won't be prioritized. Because at the end of the day, what happens is primary healthcare should take a front seat because that is a place where people generally go for in the beginning. And as long as primary healthcare is focused on, I think, disease prevention and everything, you're catching the disease at the earlier stage and preventing excessive cost towards the end.
yeah, that's the point. You catch it as early as possible, and you basically try to prevent it,
Hmm.
not make it happen.
Yeah.
Obviously, increased government revenue or increased government budget does not necessarily translate into more money for health. But you also have to look at ways that how you can increase the government budget so that it translates to, so that the government can allocate more to health. You
Right.
have to increase overall. So the best way to do that is economic growth. But when economic growth is like not a short term solution or is not as much as possible as you would like it to be. So the second sort of like the second way is that you increase the overall tax revenue and everything, but you
Right.
can also do it by putting taxes on cigarettes, putting taxes on drinks with sugar. You can do it by increasing taxes on alcohol. All that tax can be used to finance budget. But what opposition I have seen to this is that usually the Ministry of Finance or some auditing body does not want certain funds that is collected from certain places to be earmarked for one sort of like one area only. So that, for instance, they don't want funds to be tied up. For instance, if there is a health tax on cigarettes, they don't want that money to be permanently tied up to maybe private healthcare or sort of like cancer prevention or something.
Right.
They want the flexibility and they try to fight this process. But this is an important step, and obviously it's a negotiation between all the different departments, intra-government, between the society, the people, the government, and to certain extent, not to a certain extent in health, to a lot of extent, the international community at large.
Right.
And you can also have some sort of social health insurance or social health tax in which every person may be living or earning in that area contributes a certain amount to his health insurance or to the public health infrastructure. And after he like enrolls in, he gets to use that infrastructure. That is also one way. That would be, obviously it should be progressive in nature, that the ones who cannot pay are not made to pay and the ones who can pay are made to. But it's as I said earlier, that it's a negotiation between departments, between society, between people at large.
Hmm. Yeah. Also, another thing is that you have to understand that even if you're spending on health, right, a lot of times there are so many inefficiencies. Like spending on health should also translate to the result of it, right? In the sense, if you're putting this much money, you have to make sure that there are no leakages in the system. You have to make sure that, wherever you're spending on, if you're spending on a particular disease prevention or something, the result should be there. And which is why I think, like you said, right, donor funding seems to focus more on that. Whereas, like, for example, when I spoke about out of pocket expenditure and everything, one of the ways that, you can prevent that is by making sure that, medicines, etc., are also available in the primary health, like healthcare center, or like in the first line of hospitals that people go to. Because if you're redirecting them to medical store where they have to pay extra for the medicines, then obviously they're not going to go there.
Yeah, obviously one of the main, a very important aim of financing or increasing primary health funding should be like drastically reducing out of pocket expenditure. So,
Right.
paper I read like a few weeks back, and what I've seen is people at a lot of times advocate for a small user fee even at government facilities. So, for
Okay.
instance, if you go to a large tertiary hospital, people administrators and even people that work in, they advocate for maybe a small 1 rupee 5 rupee fee, so that what they call is inefficient use of OPD services, that
Hmm.
do not want anybody who is walking by and who does not need the hospital facilities, or maybe for instance, I go with my mother and I want to get her checked out. So when I go there, I'm like, oh, this is free. I should also get a prescription, and I have some not so important and inefficient use of the facility. So they advocate that if you have a small user fee, these inefficiencies and these people who do not require the facilities would not use it. But this only translates to the poorest of the poor not being able to use. And overall, we don't want to decrease usage of facilities. We do want to like increase efficiencies, but we don't want to increase overall usage. We want people to go for preventive screenings. We want people, if they feel they're a little sick, if they feel that something not right, and they should be able to like go walk into a clinic and
Get
maybe
checked. Yeah.
catch thing which would be like pretty, maybe it is fatal, maybe we catch some sort of a cancer, or we catch some terminal disease which was not showing itself in manifesting itself in a very obvious symptom.
Right.
So we have to reduce out of pocket spending, and this includes user fees. And at least in big metro cities where the government hospitals have a lot of patients, and where the staff and where administrators and everyone is overworked, they usually advocate for at least a small user fees to prevent what they call as inefficiencies in usage.
Also, I think with primary healthcare, no, it should be very clear as to how the funding is allocated and where the funding is allocated, how much of it is allocated. Like in the sense, you don't need to, sort of build a whole new center or a department for it. But whatever existing department is there in place in the country, just make sure that their responsibilities are clear towards it, right? Like again, at the end of the day, what the government does and government's will is very important for these things to happen.
Yeah, so it is, yeah, that was a very nice way to put it. We don't need a new sort of a department, a primary healthcare department or a ministry or division, but we do want sort of maybe the National Health Mission or somebody taking responsibility for all of primary health center at all of primary healthcare. And we don't want people, we should know, the people who are doing the work should know what they're responsible and what their functions are, and it should be very clearly demarcated. And whoever has the responsibility should also ensure that PHCs like primary healthcare is prioritized.
Right. Definitely.
That is a very nice. To give a short summary, we don't want a new department. We don't want a fancy, shiny new department which somebody opens with a ribbon. We just want existing departments to know what their responsibilities are.
Exactly. Yeah. So, like we were talking about like resources and I think also reducing the out of pocket expenditure and stuff, right? But what I also another thing that came to my mind was also that allocating resources to hospital is also like more politically appealing. We were talking about political will, and at the end of the day, governments have to do something. And like we were also saying that instead of having a new department for primary healthcare, we should probably make the responsibilities of the current people more clear and everything. And what I realized is that having a new department for it or having like a new hospital is always like more politically appealing, right? Because hospital is like a kind of like a highly visible symbol for health system. And it is a place where, extremely expensive and technologically forward equipments and all are there, and they sort of employ a lot of like physicians and specialists and everything. So a lot of times that seems like the most and even they are placed at an urban setting where a lot of people who have access to healthcare and everything will end up coming there. So in all of this, primary healthcare ends up taking the back seat. That's what I feel.
Yeah, so everybody, basically the people employed at the hospital, the people who run the hospitals, they're more nearer to the power centers, the urban centers, and they have more influence and sort of like a higher professional status. And they usually have more, they're more, for the lack of a better word, politically connected as compared to the PHC workers. So
Right.
they have a lot of influence on funding and who gets what. And yeah, obviously everybody every politician wants a new shiny machine installed as compared to maybe giving more paracetamol to the primary healthcare centers in his
Yeah.
district. So it's always a new shiny thing.
Right. But like what I agree with everything that you said. And I wanted to ask you, like, for example, now if we were to sort of look for allocations of resources to primary healthcare in itself, do you have any idea of how we can go about it?
So what I liked about the commission's report, what I liked about the paper was how it like simplifies and tries to integrate a lot of aspects of sort of like project management, and how it tries to integrate them into healthcare and how it tries to relate that to primary healthcare. So it talks about basically three components of sort of like resource allocation and how we can increase resource allocation to primary healthcare. So there's the budget formulation in
Mm-hmm.
which you can increase or protect from decreasing, like prevent other departments or the government from snatching sort of like revenue and make sure that it gets down to the users. Is like you form program specific budgets. For instance, you set up a program which says, oh, this is primary healthcare, and you form a budget which is allocated to primary healthcare. Even if you have some sort of autonomous financial structure, for instance, the state, I'm talking about the state as in the state within India.
Right,
So
right.
the state is allocating some money and is allowing the district to choose. They have certain rules and regulations which state that, for instance, if you will put 10 rupees into primary healthcare, then only we'll pay you, we'll reimburse you 5 rupees for that. If you'll use that 10 rupees somewhere else, we'll not reimburse you. And there's also case of conditional grants. So there are grants which are dependent on how you use them. They're specified. So those funds are earmarked for specific purposes, and you can only use them for those specific purposes. That those are not free funds; those are tied as inputs to certain programs and certain visions and certain missions. You can also change the way how budget execution goes. You can so we have talked about how you can formulate a better budget to allocate better and more money to primary healthcare. You can also see how budget execution goes. Usually in India also there's a resource allocation formula where, for instance, for 10,000 people you get this much money, for 20,000 people you get this much money. There's
Mm-hmm.
also a case of provider payments, that how you pay the providers and how efficient that system is and how those incentives are based. Are you paying the provider per person, or are you paying the provider per service, or are you paying the provider a lump sum money sort of to run the center for the whole India? There's also contracting and monitoring. You can see how you can contract specific services to specific people and you monitor them, and you can directly transfer funds to a specific facility. So there are a lot of tools which can be used to better budget execution. And the third and what I consider the most important point is that is service delivery. That you should be very clear on what is the operational definition of PHC, what are the norms and standards, how do you maintain the referral system, how does a patient which shows up at a primary healthcare facility at a primary or interact with the primary healthcare worker is referred, and is the referral appropriate? Why was the referral done? Was it done for reasons other than medical reasons? Was it done because of paucity of resources at the center? And there's also gatekeeping. We don't want people who don't require specialist or tertiary care to turn up at our tertiary centers. We want to design sort of a system where, for instance, in Europe, a lot of countries use a sort of gatekeeping in which, if you are using the government's insurance plan, sort of if you are in the public health insurance or some sort of social insurance, and you show up to a specialist without a referral from your general practitioner or without your registered referral doctor, the government does not reimburse your tertiary care expenses, at least for the consultation and maybe some tests. So
Mm-hmm.
you have to take care of three things: budget formulation, budget execution, and service delivery.
Right. That's actually, comprehensive and a very detailed answer to, like, it's a very well thought out way the Lancet has also put out, right? But like before we move ahead, Harshit, let's take a short break and we will be right back.
Hello. It's been another great week here on the IVM Podcasts Network. On Cyrus Says Cock and Bull, Cyrus, Naveen, Utsav, and Abbas discuss how COVID cases are on the rise in Mumbai. Introducing our new show, Intel vPro presents Future Proofing with Eklavya Bhattacharya, your one-stop shop for all things Web3, blockchain, metaverse, and so much more. In the first episode, Eklavya talks to Advertising is Dead host Varun Dugirala about advertising on the web. On Simplified, Chuck, Shriketh, and Tony discuss why we aren't excited about smartphones anymore. On Paisa Vaisa, Anupam and Atul Suri, CEO at Marathon Trends, talk about trend investing principles. On Smarter with Sid, Siddharth explains the 3 pillars of content creation. And on All Things Policy, the Takshashila folk analyze the Lancet Commission Report on financing primary healthcare. We've got some exciting news for you. IVM Podcasts has just launched its merch, and our first line is out now. Head to the IVM Podcasts website and click on the shop tab to check out our first collection of t-shirts. Do follow us on social media. We are IVM Podcasts on Twitter, Facebook, Instagram, and LinkedIn. And remember, if you're enjoying this show or any of our other shows for that matter, please do tell a friend. Also, don't forget to rate us on any platforms you're listening on. And you can also check us out on YouTube. We're also doing a small listener survey to better understand how you respond to our shows and advertising on the network. We would really appreciate it if you could spare a few minutes to fill it in. It helps us build better shows for you. And finally, we would like to thank our sponsors this week. SBI Life Insurance, Apne Liye, Apno Ke Liye. Jupiter, a digital banking app. Capgemini, get the future you want. Intel vPro, built for business. And Intel, future banao wonderful with Intel-powered laptops.
Hello and welcome back to the podcast where we're discussing about primary healthcare and the financing of the primary healthcare in this episode. And Harshit, you spoke about what the resource allocation tools were for primary healthcare and stuff. And in India also we have a national health mission which was created by the government of India to sort of, look after the primary healthcare structure and stuff. And I think the grant mechanism was implemented, which initially the states were required to contribute 15% of the total funds. And later on, I think between 2016 to 2017, the required contribution increased to around 40%. And also like the central government conducting detailed reviews for understanding the plans for primary healthcare as well as the budgets for primary healthcare was there. And also, there was a performance-based component that was there, which increased from like 10% to 20% of the National Health Mission funding. And the conditions were also, I think, revised in 2018 and 2019. But due to COVID-19, things have not fallen into place yet after about the revision and stuff. But I think that was one of the good things that I thought was seen in India's health system. And continuing with that, Harshit, I wanted to ask you was that what are the, we talk about funding and all of that, right? But one of the important component is payment structure in primary healthcare. So how do we sort of address that and what are the ways we can sort of think about it?
Yeah, so this make the payment, the method used for payment in sort of like financing PHCs and giving out resources to PHCs is quite important at the execution part, because this is how you shape in incentives and this is how you try to align your policy, whatever you want to see, whatever change you want to see with respect to the sort of like the money you are putting in. So what people do, what governments do is what we call as a line item. So the payments are tied to inputs. So for instance, there is a line item in the budget. So it says that 15,000 crores is allocated to Karnataka to run the primary healthcare centers. So they are not sort of like input based. Everybody accounts for how much budget they would need to pay their staff. The staff are usually on a fixed salary, sort of at least partially a fixed salary. And this is very important in hard to serve areas where you see that the staff leaving because of, and you cannot, maybe in somewhere in far away mountainous areas or a place with sparse population where you cannot tie the staff to a per person payment, or sort of like you pay them a lump sum for all the people living as per population. So you need to provide them with a stable income. And you also cannot make a very efficient use of resources because, for instance, vaccines. So vaccines, at least the COVID vaccines which we have, were coming in one vial at 10 injections. So in places where far flung areas or where people were sort of like really not very willing to, you cannot like turn people away that sorry, we don't have 10 people registered or there are not 10 people right now here. You'll have to make do with some kind of wastage and some kind of like resource. You cannot be very efficient with resources. And line items are what are usually used, but they are very important in areas like sort of like the examples I gave and basically difficult areas. So there's the next type of payment is fee for service payment, in which the provider sort of like receives a payment for a service rendered. So the problem with this type of payment is for sort of like a service which is more specialized, the provider gets more resources and more money. So they do not want to prioritize preventive care. So it can be used, but it should not be used for at least primary healthcare. It should be used for specialized care because we do want to incentivize high quality specialized care, but we do not want that to be done at the cost of primary healthcare. So the third one is population based payment, which the report refers to as capitation, which gives a fixed amount of money to the provider. And to be clear, when I say the provider, it usually means the maybe the primary health care center as a whole, or it can also mean like the
A
doctor, the
family
nurse.
doctor
Yeah, it
yeah,
can
okay.
refer
Any
to
healthcare
any
provider.
any provider, maybe, or a
Right.
like a bunch of provider group of providers which are providing
Mhm.
services.
Yeah.
So I was talking about population based payment. So what and the commission like advocates for this, and the commission refers to this as capitation payments. So they give a fixed amount of money per person for maybe a fixed amount of time, and that is paid in advance to deliver a fixed amount of and a defined set of services.
Right.
For instance, I'll give you 1,000 rupees to provide like preventive checkups to one person for an year. So that is what is called as population based payment. So this is what usually helps and incentivize providers to attract more patient, contain cost. But without proper monitoring, this can also go sort of like haywire. We don't want the provider to only to only concentrate on cutting cost at the cost of like care, patient care. So the commission recommend what it calls the blended capitation. So what it says is they provide a budget payment to cover unavoidable cost, particularly in low population or hard to serve areas. Some fee for service that is fee fixed for service for high priorities or high risk areas, and everything else is covered under capitation. Also, a little bit of performance based incentives. So that is like if we think about a normal area, a normal district, which is neither low population nor hard to serve, and has sort of does not have a very high priority, sort of like there's no endemic going on. There is no, it is not very particular, very vulnerable to maybe malaria, very vulnerable to maybe some sort of an illness which is particular to that. So that is covered under capitation and some sort of incentives, and maybe so the base becomes capitation and everything else. So you cover the corner with the other payments, but most part is paid via capitation.
Right. So, like, since you've mentioned about the capitation, and this seems quite interesting, Harshit, but now if we were to implement it in India, how would you sort of like go about recommending it?
So, what a lot of literature recommends and what seems to be working in a lot of places which are sort of like shifted to a capitation based system and were not so developed in not so developed places. The first step is you have to establish the baseline, sort of like a payment system, a baseline infrastructure where you define how the fees is paid, how are incentives made, that this should be fairly transparent, and after some debate and some input from all stakeholders and experts, and parameters should be clearly defined. The second thing is you have to similarly define the PHC package. What is covered, what is partially covered, what is not covered at all, what we think is essential and is covered, what we aspire to cover maybe sometime later. So it should be very clearly defined that what the government will pay for, or what the person does not have to pay for, and what he or she will have to pay for. The
Right,
third
right.
is you'll have to manage enrollment, that is who is in and who is out, who is covered under the population and who is not. Do you cover migrants? Do you cover people who don't live in that state or are not permanent residents? Do you cover tourists? Do you only cover certain households who who earn less than maybe 10 lakhs a year? But do you cover everyone? Or if you cover everyone, do they pay? So, for instance, is there a progressive payment? Does everybody earning somewhere between 10 to 20 lakh pays 50%? Does everybody who earns more than 25 lakhs pays everything? Or and everybody earning less than 10 doesn't? So this is all, obviously I'm making these numbers up, and these have to be debated, and I'm not very confident on, I cannot define these numbers. I'll leave them to experts, but that was only an example that how you define them. So you'll have to manage enrollment, and you'll have to also provide different payments for different people. You'll have to manage the risk. You cannot provide the provider 1,000 rupees for a healthy 25-year-old female, and you cannot provide the provider 1,000 rupees for somebody who's 70, because the provider will incur a lot of cost taking care of the 75-year-old. So you'll have to provide him more money so that he can that. And after everything else, we have to make sure that out of pocket expenditure is reduced by a lot,
Yeah,
at
yeah,
least in India.
definitely. I think in India, at least, out of pocket expenditure needs to be reduced. And I think I mentioned this earlier, especially like I think with medicines end up becoming one of the major out of pocket expenditure, right? If like these medicines are made sure that they're available in the primary healthcare center or in the with the provider essentially, to make sure that people do not have to go out of their way to get their medicines. That is one of the ways that can be reduced. And also like make sure the salaries of the providers come to them on time and good salaries are provided so that extra payment in terms of like doctor fees or everything can be eliminated. I think that is another way that we can think of reducing the out of pocket expenditure. One more I think way is also to sort of eliminate the user fees. These are the sort of three things that automatically immediately come to my head when we are speaking about out of pocket expenditures.
One more thing, Bill, I would like to add is what we call, in better words, informal payment. We want the salary to be like at least above a certain a minimum level
Yeah.
for all healthcare workers and for everybody who's providing this, so that they don't resort to take tips and informal payments, and the patient does not have to like pay out of his pocket. And yeah, so we also have to eliminate those. That seems to be a pretty thoughtful expenditure in the people's pocket.
Definitely.
So further, I would like to talk about some of the recommendation the commission gives, like sort of a conclusionary recommendation. The first recommendation that the commission talks about is that establishing people-centered financing arrangement. It says that public resources should provide the core of PHC funding. Pooled funds should cover PHC. Pooled fund is that cross divisions and cross departments and private funds also. Resources should be allocated equitably, and the system should be devised as such that they should reach the frontline providers and not be dribbled down and prone to leakages, and the frontline provider is still in paucity of funds. And capitation at core, a capitation a blended mechanism with capitation at its core. That is the first recommendation.
Right. Also, I think they also talk about how they should take a whole of a government approach and sort of like spending better in PHC. Because, just spending more doesn't mean you're doing good, right? You also have to spend more while also doing better. So one of the key things that Lancet talks about is the fact that a lot of key actors and stakeholders should be involved in sort of designing and also implementing people-centered PHC financing reforms. And basically, though it differs from, it all depends on the national context, right? What is important to the nation and what are the issues that you're going to tackle with in the primary healthcare. And the Ministry of Health should obviously prioritize primary healthcare and also sort of make sure that there are enough you have political strategies in place to support the expansion and improving the primary healthcare in itself. And they also, even to increase the funding, you have to make sure that there is proper technical expertise to take the case of more funding of primary healthcare. And also the Ministry of Finance should enable the mobilization of proper and sufficient revenue to adequately, finance the people-centered primary healthcare, which obviously is defined based on the nation and what it wants to cater to. I think that was the second recommendation that they talk about.
Yeah, one part which I really liked and which I have read like all across literature is that you should plot a sort of like a pathway in which you include everybody. And there's obviously a technical path, and there's also a path which identify how you'll engage, what would be the political engagement, how will you manage stakeholders, how the PHC will be funded at a national, subnational, global level, how will you recognize political, economic, and social conditions, how will you mitigate, manage, take advantage of them. And it also, there's an important thing that unless there is a political will and you are able to manage expectations from stakeholders and manage them, and you are able to sort of like get funds and get sort of focus to primary healthcare, you won't be able to like make at the very least basic facilities available to everyone.
Right, right. Also, I think another thing is that global agencies like WHO or like Global Health Expenditure Database, etc., should reform the ways in which, the expenditure data for primary healthcare is collected or classified as well as is reported. Because basically, what Lancet is recommending is that there needs to be a new memorandum item in place on PHC, which that it should define what PHC is and it should be included in countries' annual reporting of health expenditure to World Health Organization or the Global Health Expenditure Database. While that is happening, in the meantime, the current reporting should be adapted to be sort of based on the cross classification of functions and the providers. So, and basically, this will provide a more specific and useful data by allowing for differentiation between, hospitals and or initial providers, and also enable an proper and operational definition of PHC based on like the service delivery platform. But most importantly, I think each country should sort of establish what should clearly define what PHC is, have a clear definition of primary healthcare expenditure that is compatible with how its health system organizes its services. And then it can use this definition to sort of track the spending over the time to sort of monitor the progress.
Yeah, that is I think a very important part that people often ignore, that unless you have a global sort of like a standard, there should be obviously local flexibility, but a global standard for reporting data and everything else and global definition. So at least you could compare
There's some
across countries.
Yeah, also there's some accountability, right? At the end of the day, that okay, fine, you are going to sort of report it to this particular agency that will make sure that your expenditure is there as well as the services that you are spending on is provided at a proper level, that kind of a thing. So I feel like having a global sort of a thing would be helpful there.
It's sort of a transparent thing in which maybe I don't think, for instance, the government of India is accountable to WHO as such, but as such for funds and technical expertise, and there's international pressure. And if you're reporting in a transparent way in which the normal public can compare to other people, to other places and across time, and there's a transparent definition and everything else, so that makes it much easier to compare and to put pressure and check for results.
Right, right. Definitely.
So, Priyal, that was a very good discussion we had. Albeit, I think a little longer than what we usually do is, but it was very fun. Yeah, so Priyal, would you like to add something before we conclude this?
Though I think one of the things I would like to say is that all our knowledge about financing and everything, we are not finance majors. We're just like two people interested in primary healthcare or even healthcare in general. And whatever all our knowledge has been through reading. So definitely, please don't take everything we say as very concrete, this thing, but please do ponder upon it. That's what actually I wanted to say.
Thank you so much, Priyal, for being here. Thank you so much, listeners, for tuning in. To give the first part a listen, the introduction to this, and basically we discuss primary healthcare, its importance, and we start discussing finances.
Thank you, Harshit. Thank you.
If you liked our show, don't forget to check out other interesting podcasts on the IVM network. You can tune into them on the IVM Podcast app, ivmpodcast.com, or wherever you listen to your podcasts. You can also follow IVM on social media. The handle is @IVM Podcasts on Twitter, Facebook, and Instagram. And hey, if you'd like to dive into Takshashila's research on technology, strategy, and economic affairs, check us out at our Twitter handle @TakshashilaINST or our website takshashila.org.in.
There's a quick survey to fill out on ivmpodcast.com/survey. It lets us know a little bit more about who's listening to us. And you know what? We're going to do a few prizes. So, we'll do a random drawing of maybe 10 people and we'll send you all some swag. Remember, that's ivmpodcast.com/survey where you can fill out the survey.
We face 100 dilemmas every day while raising our children and nurturing our families. Why not let science help us make informed decisions to solve our dilemmas? Hi, I'm Devi Shobha.
And I'm Meghna. We host Big Talk About Tiny Humans, where we will help you unpack challenges around parenting and your child's development.
And more importantly, we will equip you with research-backed strategies that you can readily act on.
Tune in to our podcast every Wednesday on the IBM Podcasts app, website, or your favorite podcast platforms.